I'm going to quickly guide you through our Eposter presentation on a phrenic nerve study as inclusion criterion and outcome in clinical trials for ALS, and I will start by our take-home message, which is phrenic nerve study should be considered as an option alternative for the inclusion and follow-up of ALS patients in clinical trials, and so to be used not only in clinical practice, where it gains particular relevance in patients with moderate severe orofacial paresis, in those patients with cognitive involvement, and those who do not cooperate with the respiratory tests, namely slow vital capacity. In addition, during this COVID-19 pandemic, many centers had to cancel the performance of slow vital capacity as it is associated with a risk of aerosolization, which does not exist, of course, for phrenic nerve studies. And so we studied if it could be an option to slow vital capacity in clinical trials, and for that we replicated the inclusion criteria used in recent clinical trials in which slow vital capacity is included with a 70% of the predicted as cutoff, and we also added the mean peak-to-peak amplitude of the diaphragmatic motor responses by percutaneous phrenic nerve stimulation at the neck of 0.4 millivolts, which is in our lab our normative cutoff value. We compared these variables at study entry 24 weeks after, and we also determined the sample size using each variable in order to detect a difference of 30% in the decay rate between the placebo and the treatment arm when during a 24-week randomized parallel controlled trial with 80% power. 317 patients were included. At study entry, mean Fren amp was 0.65 millivolts, slow vital capacity 96% of the predicted. Their decay rate per month was 3.6% for mean Fren amp and 2.4% for slow vital capacity, and both variables were correlated significantly at study entry, and also their decay, although correlations were weak. For the proposed drug effect, 174 patients were needed to be included in the clinical trials if using mean Fren amp, while when using slow vital capacity, 272 patients would be needed to be recruited. And so the values that we obtained for both variables are in line with what is described in the literature. We found, in fact, weak correlations, but it was nothing that we were not expecting, as these variables do not evaluate the same aspects of the respiratory function. And as compared to slow vital capacity, if using mean Fren amp, we would need to recruit a lower number of patients for clinical trials, 98 patients less, which implies a lower inclusion period, lower trial length, lower costs, and an anticipated lower rate of missing values. And so, as we all know, and as compared to slow vital capacity, mean Fren amp is non-volitional, non-dependent on the bulbar function or cognition, and there is no aerosolization risk. It's feasible, reliable, reproducible, symmetric, with a 10% inter-rater variability, and their values decay over time, but can be recorded until there is marked respiratory involvement and intolerance to supine. And so, I thank you for your attention, and again, our take-home message, phrenic nerve study should be considered as an option alternative for the inclusion and follow-up of ALS patients in clinical trials.